My name is Fred Koh. I'm an associate professor in geriatrics at the Department of Geriatrics and Palliative Medicine at Icahn School of Medicine. And I'll be talking about frailty today. In terms of disclosures, I'm currently leading a federal funded study on frailty. There are two objectives to the presentation today. The first is to understand the definitions and clinical presentations of frailty in older adults. The second is to discuss the clinical care of frailty in older adults, but more specifically in terms of exercise interventions, patient-centered interdisciplinary care model, as well as other aspects of care, including screening, surgical risk stratification, and symptom management. So I'll start out by presenting a case. This is actually the case of my grandfather. He was around 90 years old at the time, living in Taiwan, very independent, physically active, and he lived by himself. He was someone who was able to, walk for a couple of miles a day in the neighborhood park. He had a history of arthritis, diabetes, and hypertension, all of which were very well controlled. So a few years ago, he was found to be unconscious, was taken to the hospital, and was found to have a subdural hematoma. A decision was made to proceed with craniotomy, and the subdural was drained. He had a good recovery and almost returned to his baseline physical function. After he returned home, weight loss was noted. He had frequent episodes of fatigue, some weakness, and had a few falls. A couple of years after that first incident, he was readmitted to the hospital, or he went back to the hospital and was found to have another subdural hematoma. Again, craniotomy was pursued, but this time around, his functional recovery was quite poor. He remained unable to ambulate after surgery, and he was he looked very frail. He was cachectic, had lots of muscle atrophy, and because he was unable to take care of himself and unable to ambulate, he was then transferred to a nursing home for care. At the nursing home, he developed dysphagia, for which an NG tube was placed. Because he didn't want to have the NG tube, he would pull out the tube, and that would lead to the placement of physical restraints. He had episodes of delirium and agitation, for which he had, he was given pharmacologic sedation. Pressure ulcer developed, and he had multiple episodes of hospitalizations due to altered mental status, infections, aspiration, fecal impaction. So his last hospitalization occurred when he was admitted for multi-organ failure. He had pneumonia, bacteremia that led to septic shock, hypoxia due to pneumothorax, and he had a full-on renal failure with no urine output. The medical management remained fairly aggressive, and he was given pressors, he was given antibiotics, and even albumin. The medical team offered to place a chest tube, which was declined by his family. They offered dialysis, and that was consented. He passed away before any of these more aggressive interventions took place. So whenever I think about my grandfather and how, the last few years of his life, I've always wondered if there were missed opportunities for geriatrics, palliative, and hospice care. Were alternatives to physical restraints, tube feeding, chemical sedations considered? How were the goals of care discussion carried out, both in the hospital and at the nursing home? And how well were they done? And were there considerations to implement palliative and hospice care when the timing seemed right? And lastly, I wonder whether frailty could have been used as a guide to his treatment, especially in the last few years of his life. So what is frailty? If we ask a room of clinicians to describe frailty, you'll probably get a long list of descriptions, and I listed some of them here. These will include older age, weight loss, fatigue, weakness, falls, disability dependency, multi-system physiological decline, complications from treatments, delay and incomplete recovery, vulnerability, and high mortality. So the challenge is, how do you take these different characteristics and shape them into a definition and then operationalize the definition? So one of the earliest attempts to do so took place about 20 years ago. The American Geriatric Society and the NIA hosted a conference on frailty. And through this conference, frailty was defined as a distinct clinical syndrome that was characterized by multi-system physiological decline with increased vulnerability to stressors and adverse clinical outcomes. Key components of frailty were thought to be sarcopenia, i.e., a decrease in muscle mass and strength, decreased physical activity and exercise tolerance, as well as weight loss and undernutrition. I should state that there is not a gold standard definition for frailty, but there are several definitions that have been very well defined and operationalized and validated. And I'll talk about a few of them here. The first of which is the Freed definition of frailty, also known as the physical frailty phenotype. Dr. Freed conceptualizes frailty as a syndrome with 5 distinct clinical features that are listed here. These include unintentional weight loss, physical weakness, exhaustion, slow walking speed, and low physical activity. If a person has 1 to 2 of these features, he or she is considered to be pre-frail. If 3 to 5 are present, then the patient is thought to be frail. The physical phenotype is also known as the Hopkins Frailty Assessment, and I provided a link here for your reference. Many of you have probably seen this diagram before. This is called the cycle of frailty. The 5 clinical features that I mentioned are shown here in the gray ovals. Each of these ovals could be a point of entry into the cycle of frailty, and in some ways, one could beget another. And central to the idea, again, are sarcopenia, decreased metabolic rate, as well as decreased energy expenditures. Now I'm going to shift gear to another definition of frailty. This is best defined by Kenneth Rockwood. It's called the Deficit Accumulation Index. So in this definition, frailty is thought to be an adverse state that is caused by the age-associated accumulation deficits. So in some ways, it is a multimorphous state. The vulnerability that you see in frailty is due to the aggregation of related or unrelated abnormal health conditions. One could tabulate the risk for frailty in older adults by accounting for deficits that are identified through a routine comprehensive geriatric assessment. These are some of the examples of the different domains that could be assessed in the frailty index. So as you can see, some of the physical parameters such as strength, mobility, balance are important in the Freed phenotype, are also noted here in the index. But in addition to that, cognitive function, physical functional status, as well as polypharmacy are also considered. This is an example of a frailty index calculator. This is the Beth Israel Weakness Calculator, which is available online. And the way this works is that there's a number of deficits that are assessed, that could be assessed. I think the maximum for this index is 50. For every deficit that's identified, that is scored as a 1. If it's absent, it's 0. So to tally or calculate for the frailty index, you take the total number of deficits that were identified and divide that by the total number of deficits. The typical cutoff to be considered to be frail is a frailty index score of greater than 0.25. I pulled this diagram from a publication from a few years ago, and I think it really illustrates and contrasts the differences between the 2 definitions. So on the left, we have the Freed phenotypic frailty definition. In this figure, it shows that frailty is a syndrome, and there are these outward manifestations of 5 different clinical symptoms. In contrast, in the frailty index, it is the presence of these deficits that can lead to the vulnerability that you see in frail older adults. So I talk about the two definitions of frailty. There are many tools that are developed that are based on these definitions. So one quick screening tool is called the Frail Scale. And you can see that there are 5 questions, survey questions that could be asked. And 4 of these overlap with the 3 phenotypic definition, including fatigue, resistance, ambulations, and weight loss. The scoring is out of 5. If 1 to 2 of these are affirmative or present, then 1 is pre-frail. 3 or higher is considered frail. And this is a tool that could be implemented, within a minute or 2. Many of our surgical colleagues have taken a high interest in frailty. The reason being that frailty as a pre-operative risk stratification tool seems to work pretty well. It seems to be fairly predictive of poor outcomes after surgery. So for that reason, different frailty screening tools have been developed and validated in different surgical contexts. The Essential Frailty Toolset is one of those tools, the EFT. And as you can see here, this is a brief assessment, including a physical performance test, a chair rise test, to go with a brief cognitive assessment, and then some laboratory values, including hemoglobin and albumin. The EFT has been validated in multiple studies and has been shown to be associated and predictive of mortality after an aortic valve surgery. And the last tool that I'll be talking about is the Risk Analysis Index, RAI. This is a 14-item resurvey that could be administered in a few minutes to screen for frailty for elective surgery. This is in some ways akin to the Frailty Index in that it assesses different domains of a person's health. And these include social, functional, nutritional, physical, and cognitive domains. This was developed and implemented as a pre-operative screening tool at a number of the medical centers. And the goal was is to strike that pragmatic balance between the ease of administration, i.e. at the point of care testing, and its predictive value for surgical outcomes. And this is the most thoroughly validated measure of surgical frailty that we have. This is an example of what it looks like. And as you can see, domains such as nutrition, cognition, functional status are considered in RAI as well. Because the frailty definitions have been validated, operationalized, we now have a lot of epidemiological data on frailty. So for example, in the cardiovascular health study, CHS, we now know that about 7% of the population are frail. And the 4-year incidence of frailty is 7.2%. We also know that frailty is associated with increasing age, the female sex. It's more common in African Americans and in those who are in the lower education and income strata. We also know that baseline frailty status can predict adverse outcomes. So these are data taken from the CHS study that I mentioned, as well as a longitudinal cohort that's based in Baltimore City called the WAS. What the investigators have found is that baseline frailty status is associated with increased falls, worsening mobility, worsening ADL disability, hospitalization, and mortality. This is a diagram taken from a study looking at using RAI as a pre-operative frailty assessment tool and its predictability for surgical outcomes. What the investigators have found was that RAI scored the cutoff being around 37, that the more frail the population is, the more likely for them to have higher mortality, hospital readmission after surgery, longer length of stay in the hospital, as well as longer ICU length of stay. So I'm going to shift gear to the clinical care for older adults with frailty. I think there are a number of challenges associated with this, right? I've mentioned earlier that there's a lack of gold standard definition for frailty. There's also a lack of definitive therapy and a lack of consistent treatment guidelines. And on top of this, frailty exists in a broad clinical spectrum. And frail patients tend to be highly medically and psychosocially complex. So for all these reasons, the management of frailty in older patients could be difficult. Having said all that, there is a framework by which we can think about the management of frailty in older patients. This arrow here signifies increasing frailty. So for patients who are less frail who do not appear to be frail, screening, identifying patient-centered care goals, symptom management would be key. As the patient becomes progressively or more severely frail, evidence-based interventions that have been found to be useful should be implemented as well. These would include exercise interventions, patient-centered interdisciplinary care models, and for patients who are severely frail, palliative care and hospice care are highly appropriate and should be implemented. So let's talk about exercise interventions first. You may recall this from earlier, the cycle of frailty. And as you can see, these 5 clinical features here shown in the free phenotype are features that could be improved upon with exercise interventions. And there's a lot of data that has demonstrated that, both in terms of aerobic and progressive resistance training exercises. So I'll talk about a few of these papers that really demonstrate this concept. The first is a systematic review published by Chrissy Liu back in 2009. And this study looked at physical outcomes of the PRT in older adults. 121 randomized controlled trials were included in the study. And most of the PRT interventions were performed at 2 to 3 times per week for about 3-month duration. And they were performed at high intensity. The modalities that were used included exercising machines, free weights, and elastic bands. The investigators found that PRT improved muscle strength, gait speed, and physical ability in these participants, as well as a reduction in the time that was needed for them to get out of chair. When I think about frail patients, older adults, I frequently think about those who are institutionalized or living in a nursing home, and those who are homebound. So this study specifically looked at the potential benefit of exercise intervention in patients who reside in a nursing home. The PRT modality that was used was performed at high intensity. In this study, they used an exercise machine for the lower extremities. These sessions took place 3 sessions per week over a 10-week period. And it was found by the group that this type of intervention was significant in improving muscle strength as well as gait velocity. This study here specifically looks at the potential impact of exercise on homebound frail older adults. The intervention itself consisted of a combination between home-based physical therapy that had components of balance, muscle strength, transfer, and mobility, with the use of resistant elastic band training in upper and lower extremities. With this intervention, it was found that the functional decline, the reduction in functional decline, has slowed down. for those who underwent the intervention. So I really think that there's a strong rationale for exercise prescription in terms of managing treatment of frailty. The data there really is quite strong. But having said all that, there's not a consensus treatment guideline that's specific to this. A few years ago, a few of our colleagues in Boston had suggested that the U.S. Department of Health and Human Services physical activity guidelines could be used for this purpose. And as the audience here would know, this guideline calls for greater than 150 minutes of moderate intensity aerobic physical activity per week. That could be performed in episodes of 10 minutes or more. That's spread out through the week. Muscle strengthening exercises using PRT should be incorporated as well, and this could be done several times a week as a complement to the aerobic exercise activities. I mentioned earlier that frailty exists in a broad spectrum. Right? So patients clearly have different levels of physical fitness and ability to participate in physical exercises. So I think the regimen or the prescription that the providers prescribe for the patient really should be tailored. Right? So some of the parameters that should be considered should include duration of the exercise, intensity and frequency of the exercise, and the exercise modality. So for example, having access to a machine may not be possible for some patients, but we know that the use of elastic bands as a way to perform PRT could be very beneficial. So perhaps using elastic bands would really suffice, right? In the nursing home, for example, and from the study that I mentioned, exercise machines were used. So even though the residents of the nursing home may be more physically frail, but with appropriate supervision and equipment, perhaps that's an exercise modality that could be integrated. There are a few other things that should be considered. There's a lot of data showing that structured training can really improve adherence. So these could include group exercise programs, gyms in the community, adult daycare centers, which provide exercise interventions. So I think, as a clinician, we should take it upon ourselves to really identify these resources so that patients can be referred to the appropriate settings to get these community-based exercise interventions. There's also a lot of data showing that supervised training can improve adherence. So I think it's critical that clinicians involve caretakers, home health attendants, for example, family members in helping the patient to actually commit and practice these exercise interventions. We should think about ways of involving physical therapists, whether that is done in a clinic setting or at the home setting. And I think one of the studies that I mentioned earlier has shown that even in nursing home patients, exercise intervention could be helpful. So I think it is important that for the nursing homes to incorporate exercise interventions into their restorative therapy programs for long-term care residents. I added this slide just to demonstrate what these exercise interventions could look like. There's a growing number of studies on frailty and exercise showing that multi-component exercise interventions could be helpful. And by that, I mean the inclusion of balance exercises, stretching exercises, both aerobic and exercise and strengthening training, perhaps through PRT. So this is a slide that demonstrates one such program with a combination of a multifaceted intervention. And this was taken from one of the earlier trials on multi-component exercise intervention in frail adults. So I'm going to shift gear to patient-centered interdisciplinary care models. You will recall this from earlier. This is a slide showing that baseline frailty status predicts adverse clinical outcomes. Well, it turns out that different care models, geriatrics, palliative care-based team models, can mitigate some of these poor outcomes. I'm preaching to the choir here, so I'm not going to elaborate a lot about these care models. But the gist of it is that there are different providers of different backgrounds on this IDT. And together, right, the medical psychosocial components and needs of the patient are assessed and addressed, and a comprehensive care plan is then developed and implemented. The objectives of the intervention could be many, and listed some of them here. Many of these focus on aligning the patient's care with their values. Right? So setting goals of care is key. And some of the objectives may focus on optimizing quality of life rather than quantity. This care model can be implemented in different clinical settings, including both outpatient and inpatient settings, some of which are listed here. I will only talk about a few of these models just because I think the literature is quite robust, and I think this is quite well known to the audience here. But the acute care for the elderly ACE model, I think is one of those models that's been around for a long time, that's been well studied. And the ACE model requires a prepared hospital unit, such as having uncluttered hallways to facilitate early mobility for inpatients, having large clocks to help with orientation for many of these patients who are more susceptible to delirium. Many of these units also have protocols that focus on independence, and some of them may incorporate early physical activity, early rehab within their program. In this specific study, the ACE intervention was found to increase self-reporting improvement in the ability to perform activities of daily living, as well as a decrease in discharge to long-term care facilities. I think this is the last study that I'll comment on. This focuses on comprehensive geriatric assessments, or CGA, and in looking at whether CGA can improve the health of older patients. 28 randomized controlled trials were included in this meta-analysis. 5 categories of programs we'll look at. These included a designated inpatient unit, such as the ACE model, geriatric consultation in the hospital, in-home CGA assessment. The hospital home acceptance service is similar to an early transition care model for patients who are recently discharged from the hospital, and then an outpatient paid CGA evaluation. And what was found was that CGA, could reduce mortality in older patients. It could also help to prolong and extend the duration in which one could remain at their homes. They could potentially reduce hospital admission or readmissions, and there are potential benefits in improving physical and cognitive function in older patients. The take home here is that these team-based care models can reduce frailty-associated adverse outcomes, and they really need to be integrated into the clinical care for older adults. In the last few minutes, I'll briefly go over some of the other important aspects of care for frail older adults. So I mentioned screening already earlier, and I identified some of those tools I considered. And the reason why that's important is because frailty occurs in such a broad spectrum that in its earliest phase, it may not be easily recognizable, right, to the clinician. So having some kind of screening could be helpful in that process, leading to earlier identification, earlier integration of services and care that could be beneficial. Again, some of the tools are listed here. Every institution, every clinic has their own, has a different clinical environment capacity. So the tool that would be best fitted to that environment should be considered you know, for the purpose of screening patients. Now, I mentioned surgery and frailty a couple of times already, and this is a slide that demonstrates how frailty assessment screening in the pre-operative setting can be integrated into a care model. So this is called the surgical pause practice. In this practice, RAI is used for frailty screening before surgery, for elective surgeries. If one is identified to be frail based on the RAI score that's greater than 37, the patient is then referred for a risk assessment that's done by an interdisciplinary team. And the intent of it is to reduce risk for surgery. Right? So the members of these teams oftentimes will include anesthesiologists for anesthesia management, critical care physicians, thinking ahead in terms of potential comorbidities and morbidities that could arise and complications that could arise from surgery. Palliative care frequently is either part of the team or could be referred to if it appears that the patient's care goal do not align with surgical care. For patients who are deemed to be surgical candidates, but there requires to if there's a but the patient could benefit from some pre-operative optimization, such as rehabilitation. The patient is then referred for that prior to going through surgery. In some cases, the patient may not be a good candidate for surgery, or their care goal do not align with that intervention. In that case, surgery is not pursued. And using the surgical pause model, it's been found that the model itself could be helpful in terms of reducing mortality in frail older patients. Symptom management, and this is important. Symptoms such as weight loss, especially if it's severe, physical exhaustion, could be very taxing to a patient. So, strategies that could help alleviate these symptoms are important, and they should be implemented. So for weight loss, liberalizing diet, providing the patient's favorite foods, varying the texture and flavor of foods could be very helpful. And oftentimes a patient may require some assistance with feeding oral care so that, consuming foods will be less difficult. For physical exhaustion, simply by modifying the environment and daily procedures can help to reduce energy expenditure. So this could be as simple as placing the phone within closer reach, having a bedside commode that's accessible, or reordering daily tasks by spacing out tasks that take up more energy, such as eating and bathing, and space them out by periods of rest. And that could be helpful as well in terms of conserving energy. And then lastly, palliative care program is highly appropriate for patients who are severely frail. Palliative care programs usually use an IDT model, which is, again, perfectly aligned with what we have talked about so far. And they really should be incorporated into the patient's care. So going back to the patient, I think, as my grandfather progressed through his medical journey, through the subdural hematomas, the surgeries, and end-of-life care, I really think that different components of what we talked about could have been integrated, especially as he progressed towards severe frailty. Hospice palliative care really was essential to optimize his care. So in summary, frailty is a geriatric syndrome that identifies the most vulnerable subset of older adults. Exercise intervention and patient-centered team care can improve various characteristics and adverse outcomes that are associated with frailty, and they need to be incorporated into clinical practice. Lastly, clinicians should be cognizant of frailty in older adults and incorporate appropriate screening, goals of care discussion, symptom management, as well as palliative and hospice care in their management. Thank you.